Welcome everyone to today's webinar on vaccine equity for the forcibly displaced. Welcome to everyone from wherever you're joining us. We believe we have a wonderful panel and guest speakers today to explore this underrepresented population as we discuss the issue of vaccine rollouts around the world. I'm Rosemary McCarney, and I'm a member of the Advisory Council of the World Refugee Migration Council, our host today. I'm a former Canadian ambassador to the United Nations in Geneva, so welcome to everyone in Geneva. And I'm senior advisor to the Independent Panel for Pandemic Preparedness and Response, which brings me deep into the heart of the issues of vaccine equity. Today's panel, we're going to take a close look at the need to include the forcibly displaced in the responses to the global COVID-19 pandemic. When the Secretary General said, none of us is safe until all of us are safe, we didn't think we'd have to say, and that also includes refugees and the forcibly displaced. But here we are, because indeed they are being forgotten. The refugees, migrants, asylum seekers, the stateless people, and others who've been forcibly displaced from their homes, their communities, their countries, are among the world's most vulnerable populations. So there's excellent discourse in the world right now about leave no one behind and keep the focus on vulnerable populations. Today, we're going to talk about a particular subgroup of that vulnerable, the vulnerable communities around the world. So as nations vie for shares of vaccine doses, those doses that we didn't expect to have so quickly, there's real concern that these people are being left out of the response. And this not only jeopardizes their health, but as you have heard and will hear, it also threatens everyone's health if large groups of people don't get access to the vaccines. As the UN Secretary General Antonio Guterres has said, and many world leaders have said, is that the call for vaccines has to be rolled out across the globe to all people, and their distribution has to be viewed as what they are calling a global public good. Guterres, the Secretary General, also called on other world leaders to resist any form of vaccine nationalism, and yet we see it in evidence today. So today we're going to ask our speakers, who will introduce before each segment of our discussion, where are we with these efforts and what are some of the specific approaches needed to ensure vaccine equity? And this is one of the issues that the World Refugee and Migration Council is focused on as we push for resetting the way the international community responds to forced displacement around the world. We focused as a council recently on addressing forced displacement driven by climate change, on addressing the myriad challenges faced by host countries like Jordan, by creating sustainable livelihoods for asylum seekers, and for calls to reallocate seized assets from corrupt leaders to support the forcibly displaced. I encourage you all to visit our website to learn more about these efforts and the really excellent research that we're posting there as we continue to develop networks of partners to implement the much needed actions our council has proposed, including our major report, A Call to Action, Transforming the Global Refugee System. But let's get started. Please, and don't forget to continue to contribute your questions in the Q&A box. And we're going to do our best during this discussion to respond to them and get to all of them. Let me begin, though, with two leaders, both very committed to vaccine equity. First, His Royal Highness, Prince Al Hassan bin Talal of Jordan. Prince Hassan is an honorary chair of the World Refugee and Migration Council, and he's been actively engaged from the very beginning in the council's work, especially through supporting continuing council research on issues facing Syrian refugees and the countries hosting them in Jordan and in the region. So Your Royal Highness, to get us started today, would you share some of your thoughts on how world politics are complicating the response to vulnerable populations, including the forcibly displaced, at a time when we really need countries to be coordinating their efforts? Thank you, and over to you, Prince.
In terms of the outreach of this program, the Thonian world of vaccine nationalism, as it has been described, politically crafted and implemented on the basis of status, that is to say categories such as the national versus the non-national, producer versus consumer, exporter versus importer, I think has to yield in these days towards a policy as opposed to politics, policy crafted and implemented programs on the basis of and with an eye towards alleviating vulnerability. So from the status-based approach, as UNHCR would say, to the vulnerability-based approach. And I would like to suggest that the advanced economies, including the US, the EU, and the UK, have once more, and this time on the 10th of March, blocked the petition made by over 100 countries, mostly developing countries, for a temporary waiver of trips. And we can come back to that, but the demonstration is quite articulate in Geneva outside the WHO building, I believe. The fault lines of yesterday's globalization continue to be the fault lines of today's. And I would suggest that whereas Europe, North Africa, Australia, South America will achieve widespread vaccination rates, we are told, by late 21 or mid 2022. On the other hand, Africa, which has, as I must remind you, the siège, the foyer, the home to more than Europe and North America's populations combined, West Asia, or the heart of West Asia, the Levant, of which I would like to express deep concern, has been raised by conflict. And in that context, I want to say once upon a time, opposite number in one of our meetings with the Israelis, Shimon Peres, said to me, you know, we are surrounded by enemies. I said to him, well, you must have an enormous problem and a historic problem on which I can't comment, but let me just tell you that we are surrounded by friends. And going back to fault lines, I would like to suggest that further disparities will be visited on us in greater emphasis, and I mean sociology will become socio-side, and poverty will become greater poverty, and injustice will become greater injustice. If we are to believe what is written in Haaretz, the Israeli newspaper, and reported by Jean Stern, in which he says, the campaign against vaccination has started on Monday the 8th. Don't forget that Israel has elections this evening, culminating this evening. And these vaccinations are for 120,000 Palestinians in the occupied territories working in Israel. So that means that COGAT, the Organization for the Coordination of Government Activities in the territories, an organism of the army, manages the occupation, but also manages the checkpoints, which have to be checked every day, whereby a Palestinian pays his dues, presents his identity card, and is recognized. On the 7th of March, 4.9 million Israelis received a dose of vaccine Pfizer, which of course is a great achievement, and 3.7 doses of the tens of thousands of others of the vaccinations every day. So a triumphant prime minister declares we have done it. And the uninformed writer will say, well, Australia, like New Zealand and Israel, have done. I would like to suggest that Australia and New Zealand are somewhat isolated in their relative bubbles, whereas we are affected by our neighbors. We have 1 in 3 of our population is a refugee. It's not an academic exercise for us, either a Syrian refugee or a Palestinian refugee, and we host up to 50 different nationalities. So my question is basically to all of you, if Israel is regarded as a model country, as Patty Much has told us, and that the Palestinians have been excluded. How can we justify inclusion and exclusion at one at the same time? I believe in the inclusion of the whole of the Levant, and I hope that the Austrian Chancellor Sebastian Kurz and the Danish Prime Minister Mette Frederiksen will be able in their conversations to focus on this essential central issue, which is the dignity of people under occupation. And in that sense also, we recognize the generosity of Israel in offering a few thousand doses to Honduras, Guatemala, Hungary, the Czech Republic, and of course, this is good international public relations. But as far as the Palestinians, they have received 7,000 doses, 5,000 reserved for those actually suffering, and of course, others to privileged groups of people. I'm not saying that Jordan has done other than what you will hear from the former Minister of Health, making the best available of trying to reconcile the arguments between economic pressures and human pressures. But I'd say that in terms of the social determinants of COVID, our biggest problem is either prejudice in not taking the vaccine, with some people saying this is going to prevent fertility, and others saying, well, this is going to cause some form of complication or another. And of course, the deep air of irresponsibility, which seems to affect many countries in the world. Under the name of freedom, I would like to remind my listeners that the worst form of freedom is freedom from responsibility. Will we learn from a pandemic? And if we don't learn from a pandemic, when will we ever learn? I chose to speak about one of our neighbors, but of course the Syrian situation is well known to many of you. And we have, of course, willingly paid the price of hosting Syrian refugees, Iraqi refugees. And I would just point out that we are also being innovative. And I would like to thank a Jordanian co-founder of Future Health Biobank, who in 2020 was the co-founder of the Clinical Middle East, which is based in Amman, a center which specializes in bringing cutting-edge diagnostic tools to markets in the Middle East region. And we are bringing to the market a US brand COVID-19 rapid antigen test cassette, nasal swabs, and other definitions of the same. I want to thank you for giving me a chance to address issues which I'm sure will be expounded on by many who are more specialized, including Mr. Zain Danger, the principal advisor to the government of the Republic of South Africa. And as I come from what is often described as the global South, I look forward to listening to him and welcoming him, as I do many of the diplomatic corps in this country and beyond. I do hope that the objective of Big Pharma, which has rejected the proposal that would grant compulsory licensing by overriding patent rules, will, as I served as an advisor years ago on IPI board, will have some resonance, particularly as Britain, Switzerland, and US, which have strong pharmaceutical industries, have opposed the waiver. I do believe that we can only get this right in terms of the 10 million doses which have been delivered in more than 10 countries, by saying that's a huge step forward in terms of at least the beginning of the journey, but towards better vaccine equity around the world. We should not be looking solely at when this vaccine can be made available, as it is commonly in cases of influenza and elsewhere. So as a hinterland country to the Arabian Peninsula, like Yemen, like Syria, we are doing our best to muddle along, but that is not going to last long without international understanding. of human dignity. So thank you for that opportunity.
Thank you very much for getting us off to such a great start in terms of your oversights of the situation in the region, and in particular your comment, if the world cannot learn from this pandemic, when will we ever learn, is certainly the question that I think all of the panelists are going to hopefully be able to point us towards. Let me turn now to the Honorable Lloyd Axworthy. Mr. Axworthy is the chair and founder of the World Refugee and Migration Council, and a former Canadian Minister of Foreign Affairs, where, frankly, as a Canadian, I can say he led some of Canada's most significant multilateral contributions, which we are still profiting from to this day. So, Lloyd, over to you.
Thank you, Rosemary, and welcome to everybody. I want to start by thanking His Highness for helping to put together this particular intervention. He and his staff have worked hard to organize. Also, a great deal of thanks to the panelists. It's an incredibly sort of impressive group, so I won't take much time. I'm more interested in what they have to say. And to you, Rosemary, for taking on the sort of exquisite choreography of this group. I just will take a minute on a reflection. Several months ago, when the epidemic was really into its surge phase, our council organized with the Girl Group. It's an international group of women and girls refugees around the world to set up a digital virtual connection for many women and girls around the world to determine how the epidemic and the virus was affecting them. That was before we had the good news about vaccines, but I think that what they said has struck and resonated with me ever since. That they basically said that when it comes to remedies, responses, promotion of well-being, they are the very last in the queue. And I think it's become even more sort of problematic because I'm not even sure that they are in the queue anymore. And so even though there's a lot of sort of international discussion about the need to fairly share, distribute not only the vaccine, but the other forms of public health measures that are required, very rarely do you hear the specific concern of the 80 million people around the world who have been displaced, forcibly displaced, with the number growing. You know, what we're facing right now is a kind of a confluence. You've got an epidemic, you've got a climate change, you've got a breakdown of governance, and sitting behind it is the times when there will be nuclear weapons because they're always a threat to. So we have a existential threat that I think put us on the precipice. And I think the point that you made that you can't do this alone, because while there has been an extraordinarily historical demonstration of cooperation by scientists putting together this kind of rapid rollout of vaccines, the paradox is that on the side of cooperation, collaboration, unified efforts, we have become back in the 19th century, where every country and every government is pulling up the bridge, sort of building the wall, and being basically securing their own domestic needs, but making that fatal mistake that we're not islands unto ourselves, and that if you don't deal with the health and well-being of your neighbors, of your friends, of your in today's world of global transport and commerce and connection, if there isn't an equitable sharing, if people are brought back into the queue and given a voice, but I think that we will be suffering much further down the road. So I look forward to what our panels have to say. But I would ask them if they could address that fundamental issue, which I guess coming from a parliamentary or political background, my basic question is, you have to give people a voice in the decisions that affect them. And right now, that's not the case. So let's open the show.
Lloyd, thanks so much for that. And you always have the perfect turn of phrase when you move. It's bad enough being at the back of the queue, but if you're not even in the queue or being counted, and we often hear the expression, yeah, women and girls are not at the table. This time they're not in the line. And if they're missed, if they're missing, are they even being counted when we talk about these aggregated numbers? So, you know, to your point, I think we're still a year in, and now year 2 of the pandemic, we still have this patchwork of responses where the most vulnerable populations are in the most frayed parts of our patchwork quilt of fractured responses. So let me bring up the panel now, and thank you both, Prince Hassan and Lloyd, for those opening comments. I'd like to introduce our brilliant panel today. We have with us Dr. Rana Hajjeh, who is the Director of Program Management for the Regional Office of the Eastern Mediterranean of the World Health Organization. And she was previously Director of the Department of Communicable Disease Control up until May 2019. We also have with us Dr. Anders Nordström, who's the head of the Secretariat of the Independent Panel for Pandemic Preparedness and Response, on leave from his position as Ambassador for Global Health at the Swedish Ministry for Foreign Affairs. Anders also serves on the board of UNAIDS and Gavi and the Global Fund to fight AIDS, tuberculosis, and malaria, which I'm sure we're going to hear about as well. And then finally joining us is Dr. Saad Jaber, who until October 2020, a few short months ago, was the former Minister of Health for Jordan. And Dr. Jaber has previously served as the General Director of the Jordanian Royal Medical Services, and was deployed on several humanitarian missions in his career. So thank you all for joining, and I'm looking forward to this conversation. But let me start, if I can say, Dr. Hajjeh or Rana, given your role in the World Health Organization and in the region that you're sitting in, which has a preponderance of displaced people from the conflicts in the surrounding areas, how does WHO specifically address the vulnerable communities like refugees? Given the range of programs you see starting up, are they contributing, or where do you see the gaps?
Yes, thank you very much, Rosemary. Can you hear me?
Very much, thank you.
Great, thank you very much, and good afternoon or good morning to our colleagues in North America. And thank you really for Your Excellency for the opportunity to be part of this and actually highlight some of the challenges and the issues we are facing in the region, in the Eastern Mediterranean region. Maybe, Rosemary, please allow me, before I answer directly your question, just wanted to put a little bit of context to the situation of refugees and migrants in our region, which includes 22 countries, most of the Arab world, in addition to Pakistan, Iran, and Afghanistan. As you know, this is a region that has been troubled, unfortunately, by many wars and conflicts. Many of them are chronic. And currently, we have almost about 5% of the total population in the region is refugees. For some countries in our region, like Lebanon and Jordan, refugees actually constitute a big part of the population. In Lebanon, almost 25% of the populations are Syrian refugees right now, in addition to also many other refugees like the Palestinian refugees who have been there for a long time. And I'm not talking about just the short term or the recent conflicts, but some of the long-standing conflicts like the Palestinian refugees in our region. So I think this is something to put in context, because it puts huge strains on countries that are already overburdened by years of conflict and other wars in the region. And now we have also the additional responsibility of really addressing the health needs of the refugees. So what we have been doing in our region, actually it was a WHO recommendation by SAGE, our advisory group on immunization, to include refugees and migrants, or actually all vulnerable populations, with specific focus on refugees and migrants in all the national vaccination plans. So as you know, countries, definitely as part of COVAX facility, countries were asked to develop national vaccine deployment plans. And countries were encouraged to include all of the refugees and migrants in these plans. And just in case, because we know some of the countries are not able also to finance some of these vaccines needs, COVAX made actually also as a recommendation by SAGE to have what we call a humanitarian buffer, which is 5% of the vaccines that will be provided or procured through COVAX to actually be kept aside for refugees and migrants in case their host countries cannot cover them. So that's what's actually the recommendations. You know, the implementation on the ground is facing a lot of challenges. Maybe, you know, I want to put it in the context of the pandemic. We've been lucky. We still don't fully understand why, but we have not seen major explosive outbreaks among refugee populations in our region. And actually, when the pandemic started, this was one of the issues we were very concerned about, because of you know, the conditions they live in, the crowded you know, housing situation, some of the, you know, the many weakened health systems and infrastructure. We have not seen that. We've seen some in migrant populations, especially early in the pandemic, among migrant workers in some of our Gulf countries. These were addressed very quickly at the time. But so that's this is somewhat, there's always a bit of a silver lining. But we are working very actively with the countries to ensure that no one is left behind when it comes to vaccination. Maybe later I can address more specifically some of the challenges. Thank you.
Thank you very much. And it is a good reminder, and it's whether we're still kind of in apprehension, anticipation mode, because it is counterintuitive. We thought that that there would be really destructive outbreaks in those close quarters of the way so many displaced live, and it hasn't occurred at least at the scale that we might have anticipated some months back. So it's really helpful. Maybe we can explore that. Let me turn to Dr. Anders Nordström. Anders, you know, it's clear from the work that you're doing that the response to the pandemic has to be a global response. And at the national, we need responses at the national level to be robust and well resourced, et cetera. But whether it's high, low, or middle income countries, there are people being left behind and constantly. And so, you know, as you reflect on how much your waking hours are spent grappling with how do we do this better next time, and how are we better prepared and respond? When you take a multilateral perspective to this, what are your thoughts in terms of how we respond multilaterally so that there's not this patchwork of responses, well, as we continue through this pandemic and on to the next one?
Well, thank you, Rosemary, and delighted to be joining you in this discussion. I would like to share two perspectives on this question, which has to do with the mindset of international cooperation and global work today. And the second one is then the effective flow of vaccine, given the situation we have right now. You were referring to that I was on a couple of boards. I'm no longer on those boards, but I have been on the Gavi board, and I've been on the other organizations boards as well. I've been working on global health now for 31 years. What is different with this outbreak and this pandemic, if I compare with HIV/AIDS or polio, is that this has hit all countries across the world. we have suddenly something that is no longer only about the global south, low and middle income countries. It's a disease that has affected all countries across the world. That has then mean that it's triggered also a discussion about what should global cooperation be about? What should an international system be about? Again, where I'm coming from is mainly been then in this sphere of organizations that have been dealing with development, focusing on poverty reduction, and then health being a critical dimension to this. But suddenly now we have a need to have a global system that takes global responsibility, that sees the benefits of multilateral cooperation for something that affects all countries across the world. And I think the vaccine is a very telling example of where the world has actually failed. But before going on to that, I believe that there is a need for a shift of mindsets here, to think differently around international cooperation and global health. It's no longer about the old paradigm. Now what we're living and what we will live again in the future, if we don't change, is something where we need to be much more interconnected and working together across the world. So that is my first reflection. The second one is then on the vaccine specifically, because I think, as I said, the world or the international system has failed here to get organized for an effective flow of the vaccine. And I'm not saying an equitable flow, but an effective flow from a public health perspective. Because I think that's the second reflection here. If you should have an international system that works effectively, you need to be clear about what are your goals and objectives. And when it comes to vaccines, I do not think that the world is clear enough. Is the objective to stop the outbreak? Is the objective with the vaccinations to save the lives, the most vulnerable? Is the objective to make sure that the health systems cope by first prioritizing the health workers? It might be a combination of all three, but before we are clear about what are the objectives, then we can't have an effective flow of the vaccines. Today, we are talking about equity more generally, like everybody should have the equal opportunity to get immunized. Personally, I don't think so. We need to be clear about what should be our objectives from a public health perspective, and then ensure that we have an effective flow of the vaccines according to what we have agreed to be should be our objectives. And I don't think the world has managed that. And I think the world has also been overtaken by national interests here, protecting your own country before you see that you actually need to get an effective flow, as I said, of the vaccines across the world, because only protecting your own country, whether it's like my country, Sweden or Jordan, I mean, you won't be safe until the rest of the world is safe, as had been said very many times, and many political leaders agree on, but they don't do. They don't walk the talk. They don't take the implications of actually agreeing to that and seeing that what is good for your country is only when we have a solution across the world. Then that must lead to certain actions, certain consequences in terms of how we, again, manage the flow of vaccines. Today, WHO is working on an allocation framework model. Unfortunately, personally, I think it's coming too late. And there is also, WHO is doing a tremendous good job on this, but the political commitment to agree on what should be the principles, what should be the objectives, and then ensuring that we have this optimal flow of the vaccines across the world, we don't have here. So I'll finish just to say that the only solution to deal with global challenges is to work together. And we need a multilateral system with key stakeholders, actors, organizations that have clear defined functions for the future. And it's now time to reflect on both what worked, and there's been a lot of things that have been working extremely well, to move from this discovery of the new virus to the R&D to actually having vaccines. Never been done so quickly. But then there are other aspects when it comes to the effective flow, the financing, etc., that has not worked well enough. And I think now is the time to reflect on this, to see what hopefully governments can agree to do better next time. Thank you.
Thank you very much. I think one of the points that you made, that it's an important one that I think we'll keep exploring, is, you know, the need for it, to make the multilateral system work effectively on a global pandemic. We need a shift in mindset. And so the shift of our risk assessment on health is not up to the level, say, our standing risk assessments on things like chemical weapons or data threats, cyber threats, etc. And we need to bring health up to that level and be in that state of readiness. And that's what the multilateral system is going to have to work on. But it really does require a global shift in terms of risk assessment that also embraces health at the same level as these other ones. And I think the other one that is now, Prince Hassan mentioned, Rana, you mentioned, and Anders, you did as well, is that you all use the language of responsibility. And if I recall correctly, Prince Hassan said, you know, responsibility does not mean responsibility to do nothing. It means you've got to step up. And so I think one of the countries that has shown a way to do that is certainly Jordan. And so I welcome Dr. Saad because Jordan in mid-February was the first country to vaccinate refugees and set up a vaccination center in the Zatari camp, which I visited a couple of years ago with UNHCR. Dr. Jabbar, Jordan has demonstrated this leadership on taking an inclusive approach to the vaccinations. What have been the challenges in doing that? You know, what has been the role, partnering role of UNHCR and other international organizations to enable you to get that done?
Well, good evening to everyone, or good morning to our fellows in North America. Well, thank you very much for giving me the opportunity to talk to you. Well, early since this pandemic started, we knew that the vulnerable refugees should be protected because of the sanitation and their situation. So we we did not allow any people to go into those camps without being scrutinized or tested. And this was one of the reasons protected them from outbreaks and devastating sequelae. And we, with the other NGOs and UNHCR, we started building mobile hospitals and even fixed hospitals with ventilators and everything to host any outbreak there before transferring patients to regular hospitals. I would like to say that early, since the refugee crisis started in Syria, Jordan was overwhelmed with the huge number of refugees. And at that time I was in the military. It was, living it was totally different. I mean, at the borders, I used to go with the military medical teams at that time. And refugees used to come hundreds or tens of kilometers or miles walking in very bad health situation, thirsty and hungry. Some of them have to give birth at the borders, and we have to ship them quickly to camps, giving them emergency medical aids. Then we realized with the increased number that we can give them shelter, but not home. So we started to incorporate them and make those refugees intermingle or be transferred to live among the general population in Jordan. And we gave them tuition, medical insurance, and work opportunity so that they can live in dignity. And I think the number in camps is far less than the general number of refugees in Jordan, which reaches 3 million refugees nowadays. Only less than 250,000 are in camps. So we have to protect those in camps with UNHCR, building mobile hospital, bringing experts to work there in the field. And we incorporated those refugees among our testing strategy early from the start. When we were negotiating with COVAX and with Pfizer, we incorporated the refugees in our negotiations, and with Pfizer, 12.5% of the doses of the vaccines were dedicated to refugees. So that was our request, and it was incorporated in the deal. And this was reflected by putting a vaccination center in the refugee camps where we vaccinated a lot of refugees, and they are incorporated now in our national program of vaccination among COVID. We believe in Jordan that this virus has the ability to mutate, and transferring this pandemic to an endemic area, I mean areas where it is affected and others are not, will create mutations that will be resistant to the current vaccines. So everybody on Earth, on the globe, should be vaccinated to protect everybody. There has never been a need to stand together as humans and authorities together to eradicate this disease. Otherwise, it will continue to mutate in a remote area, neglected, or vulnerable people not being vaccinated, where this virus might change and our current vaccines will be useless for everyone. And this disease will come in another lethal form. So I will not add, to what His Royal Highness and our panelists said, but I think also it is the time for political solution to the conflicts in the region, which is in the middle between East and West and affects the life of everyone on the globe. Globalization is a fact, and we are all affected, and this pandemic has proved that. We will continue in Jordan vaccinating the refugee and forcibly displaced, because we believe in Jordan and in the region we will not be able to eradicate the disease without vaccinating everybody. Thank you very much.
Thank you very much, and I think Jordan is set a bar for other countries to certainly to follow and to model and to learn from. Both the objectives you set out, but also the challenges of actually getting that job done on the ground, because it's a heavy lift, and that kind of brings me back to you, Anders, a little bit, because when Dr. Jafar talked about, you can give shelter, but you also have to give hope. And hope for most people around the world in vulnerable populations right now is that they will have vaccine access. It's not the only tool that we need, but it's certainly one of the most important ones. So, we can give the physical side of things, shelter and food, but hope is an important part of all of this. So when we think about the platforms that are there, that we maybe need to fill in gaps for effective and equal access, and how we fund those. So, I'm thinking about, we have COVAX, we have the COVID Tools Accelerator, we have CEPI, the Coalition for Epidemic Preparedness and Innovations, we have the International Vaccine Institute. There are lots of institutions, organizations, etc. And yet we're still kind of challenged and struggling about getting vaccine access to that last mile. What are your observations? Have we got what we need? Is there more that we need?
No, thank you. And I share the frustration, and I was even saying that the global system or global community has failed to get an effective system up and running for an effective flow of vaccine. On the same time, again, with a little bit of historical perspectives, we've never been able to do something as quickly as we are doing now, going from research, the discovery of the virus, actually having now a number of vaccine candidates, or not candidates, but real vaccines up in production, and actually also sharing them across the world. So in some way, if you take a step back, it's actually gone quite quick. And if we look ahead, what is in the pipeline in terms of volumes of vaccine, it actually looks quite good. But we have a big challenge now, because we also have a society today that is much more connected. Everybody knows about everything today, what is happening across the world. So people know, of course. And because of that, people are also having expectations, reasonable expectation, that they will also have access to this, which is very good. But this is also really pushing the whole issues around the inequalities of the world to the point, sort of. And that is, of course, leading to frustrations. But I think the structures that were in place and have also now been put in place. CEPI is an R&D platform to stimulate now research and development for new vaccines that was already in place. I think for the future, that's an important mechanism to have, to continue to invest in R&D. That should then also be publicly available then. COVAX is really the big sort of facility to be able now also to manage needs with access to production capacity and vaccines that are being produced, matching that with financing and then distribution. So that's enormous machinery. And I think there are a lot of progress, as I said. I think just looking now the last 2, 3, 4 months, what that modality has actually delivered, huge progress. But still, of course, it's not good enough. There is still a lack of really buy-in from very many countries to see this as the global platform. There are big vaccine producers that are not included. The issue around the financing is still not good enough in terms of how you will manage also the trade-offs here in between the self-financing countries and the countries where we will also put in some extra money from the from the international community. So there are challenges, but I think for the future, again, if one takes a step back and thinking what structures are needed, one should think about functions. What is needed in terms of a convener, and I would imagine that WHO is a natural one. What is needed in terms of actually making sure we invest in the R&D. What is needed in terms of the engagement with the private industry, who is actually going to produce a vaccine or a diagnostic. And how do we also organize the financing and ultimately then the actual supply and distribution of the vaccine in the best possible way, where there's also support. So I think when we look at the ecosystem, one should look at functions. No one can do all of those functions in terms of international organization, with all the respect for WHO, but you can't do it all. So there is a need for an effective ecosystem and effective partnership here among partners. And I think there is a good momentum for that, but there is a need to have an openness to learn and to adjust based on the experiences this far. Thank you.
Well, thank you very much. And I think that one of the things that you said is this expectations, and certainly, looking at the dissemination of information and disinformation in real time, it has certainly created a frustration as well as momentum. So it's kind of a double-edged sword, isn't it? In terms of people's expectation that, well, the vaccine was created in rapid time, the distribution should be equally quick and as effective. And so the expectations are very hard for global leaders of institutions as well as political governments to manage those expectations and certainly to meet them. But it has put some healthy pressure into the system as well, but challenging for those who are in charge. Let me come back then to Dr. Jabbar first, because I think that what Anders has said is that, we have the knowledge, and then if I take then kind of the one country of Jordan, you have that knowledge, you now have some best practices with all of the challenges of getting that rollout done to a very difficult population, challenging population. And it has to be funded, of course, because all of these things that you discussed take money. Can you talk a little bit about how you're doing that knowledge transfer, particularly to other countries in the region who are also hosting very large refugee displaced populations? Are you coordinating that at least across the regions? Because that's one of the areas we find of high potential, that neighboring countries sharing kind of technology transfer in the sense of how to best do this. Could you comment on that, Dr. Jabbar?
Yes, Amman is the place for many NGOs in the region because of the stability and security present in Amman. So we are cooperating closely with WHO, UNHCR, and other global organizations dealing with refugees, especially in Syria and Iraq. So we cooperate closely with them to deal with the refugees in Jordan. And the same people working with us in Amman, they go to and fro to Yemen, to Iraq and Syria, even to other areas where refugees are there. So when they transfer some of the models with some changes according to each country's particulars, but in general, our teams cooperating closely with WHO teams and UNHCR work together to help other refugees in the region. Generally, Amman is a hub for vaccines and help to other countries in the region for easy transfer of goods, vaccines, and medical equipment. And most people working in the region, they have Amman as their place to come and discuss issues regarding their medical issues. So we were in deep cooperation with UNHCR and WHO regarding cholera in Yemen, and how to deal with it, sending vaccines and helping Yemeni people in dealing with that issue. And in the last year, the number of cases in Yemen had started to decrease markedly. Also, Jordan was the place to transfer people working in NGOs as a place to treat them when they were affected by coronavirus. So the experience has been moving there, and the knowledge is transferred through Jordanians and international workers working in Amman to the whole region. I think we need a lot to reach a state where a free transfer of information and help can go without borders, sans frontier, let's say that. And I think we have done something good with our partners, mainly WHO and UNHCR. And I hope in the coming future, we'll see vaccination centers in their locations equally to the general population. Vaccine nationalism is not a solution. Thank you. No, it's not.
No, the virus knows no borders. The vaccine should know no borders either. You're absolutely right. And I think to your point, this rapid transfer of Jordanian know-how in terms of how to access the refugee displaced populations with mobile clinics, et cetera, is an important one to share to like countries, not just in the region, but elsewhere. And certainly the experiences that we're seeing is that a lot of populations, including, say, the elderly and the general population, can't move to the vaccine. We've got to move the vaccines to the people. And so I think this rapid transfer of know-how and experience that you've described in Jordan is a very important one. So thank you so much for that. Information should know no borders either. Dr. Hajjeh, can I come back to you? So you're kind of in the heart, in the institutional heart of these issues that both Anders and Dr. Jabbar have described. Can you talk a little bit about kind of your challenges, your institutional challenges as WHO in terms of the equitable distribution among the forcibly displaced in the region, particular things that are unique to your situation?
Yes, thank you, Rosemary. And I've been listening really, I think I agree with all what was said. I mean, I can talk for hours about the challenges. I will try to maybe—
We have a lot of questions in the chat.
I know. I will try to address some of the more critical ones in a few minutes and maybe try to propose some recommendations. I'm not used to talk about challenges without proposing solutions, but you know, it's I think as was said, I mean, the whole process happened so quickly, the vaccine development, that it posed global challenges in terms of ensuring availability of the vaccines in real time. And this was not just for the refugees and the migrants, this was for many of our countries. So what we are seeing in terms of ensuring our refugees and migrants and our all other vulnerable groups in our countries have rapid access to these vaccines is part of a more global challenge that we faced with the allocation of COVID-19 vaccines. So I think if I can summarize them, maybe two major issues, the financing issues and then the logistics and operational issues. So financing is an obvious thing. Many of our countries are already facing major financial constraints in the region and the financing even for their own populations. I mean, many of our countries, including the countries that were not part of the advanced market commitment, which is the more fragile and the lower middle income countries in our region, even those were facing major challenges. I think it helped to have support from other organizations, to have donations in certain cases. For example, Lebanon benefited from a World Bank loan. That part of it was also used to support the vaccination, the cost of the vaccines. That was very helpful. In Jordan, which I would really like to commend the Jordan experience, I think it's a model for many countries and the interest that they have shown in ensuring refugees are treated similarly to the rest of the Jordanian population. I think it's very advisable, but also I think it was good to get, for example, also some support from the European Union to support refugees in Zaatari camp vaccination. That was very helpful, and I know the Ministry of Health was really very actively engaged and working closely, as Dr. Saad mentioned, with UNHCR, WHO country office, UNICEF, many other colleagues on the ground. One of the major challenges we have with the financing is that sometimes we have financing for the vaccines, but the operational costs of administering the vaccine are very important. So I think we need to really ensure always and remind donors that the operational costs are very important for these vaccines. What we are facing sometimes, the lack, as I mentioned, logistics, but it's the systems in place. So in many of our fragile countries where there are many refugees, we already have problems with the weakened systems, whether it's immunization systems, the cold chain, all the other requirements that were important for the country to get vaccine to start with. And of course, it will affect access of refugees to these vaccines. So having strong systems in place to start with, and the immunizations programs had always been the strongest public health programs in countries, was very helpful. In countries where we had strong programs, it was much easier to introduce the vaccine in the country and in others. And I would like to mention, for example, the experience with the Palestinian refugees. Of course, we don't advocate for many of our refugees to stay in camps for over 50 years. But for example, UNRWA had a very strong primary healthcare system in place. And as a result, they were able quickly to mobilize to ensure the vaccines reach the refugees. The shipments, as was mentioned already, the global shipment also network is an issue. We're also lucky to have the Dubai hub, which is one of our WHO hubs that has been set up before and has proven to be very useful during the COVID pandemic. Many of our countries, as I mentioned, had already low vaccination coverage. Some areas are difficult to reach because of security, because of other issues. So that was one of the big challenges, even for some of our refugees. And then, one maybe last challenge in many of our countries, many of the refugees are sometimes unregistered. And this is where we need to really rely on that close partnership, working with all our partners, with the civil society, with the NGOs on the ground who are able to reach these refugees and ensure they have access. And last but not least, as Anders mentioned, that even though I think it's kind of like an obvious thing, ça va sans dire, as they say in French, that we need to have that global responsibility. Maybe the COVID pandemic has taught us that we need to start relying more on ourselves. In terms of vaccine production, we noticed that in our region, this is actually between us and Africa, one of the two regions that have the lowest regional vaccine capacity. So we are trying to revamp and work on a regional plan to revamp regional vaccine production so that in the future we'll be able to do more procurement. And we really, we believe, and we've been working with our governments very closely, that no one is safe until everyone is safe. And maybe we need to be more convincing with this slogan so that all countries can see why it's important to protect all the vulnerable populations so that their own populations will be protected as well. Thank you.
Thank you very much. And in fact, you've given me a lovely portal to have Dominique Hyde join us. Dominique is the Director of External Relations with UNHCR. And Dominique, you know, now kind of come to a little bit of a place with respect to the role of UNHCR. And Rana answered one of the questions in the Q&A regarding unregistered refugees and how are we accessing them. But could you speak for a couple of minutes just in terms of, you know, UNHCR's particular role in ensuring equitable access to vaccines for refugees, particularly in the conflict areas? Many people have asked about, what about Yemen? What about Syria? Under the protection mandate of UNHCR. Maybe you could help us a little bit with that, and welcome.
Thank you, Rosemary. And I guess it's just so exciting to see so many people supporting our cause, supporting refugees getting equitable access to vaccines and understanding the importance of this. And I'm rarely on panels where there's so much cohesion and we need more of this. And as Lloyd said at the beginning, it's not just about refugees, it's about the 80 million that are forcibly displaced. It's also about hearing their voice. And so, you know, Syria, Yemen, obviously those are good examples where there is a mixed type of populations of displaced people, of refugees. And in many of these conflict areas, the situation is very complex. We heard this also from our WHO colleague. Medical facilities have already been severely impacted in these countries, and medical staff are far from being at full capacity. So that's just another problem that is being faced by refugees and displaced people in these countries. And access is a real issue in some of these countries. In some countries, it's restricted, it's complex. So how do we do our work? How do we reach the most vulnerable? And I think that's also part of the dilemma and part of the challenges, as well as the registration that was mentioned. The question is also, how can countries take concrete steps to support this equitable access? And I think it's been said, I'm going to repeat it, refugees and displaced populations should be subject to the same standards and in the same way as everybody else in the population. And so, for example, refugees should be given priority when they're part of the elderly group, when they're health workers, and that just should be how it works. Unfortunately, they're most likely to be left behind and are a group that is a major concern. So how do we avoid this? Well, by doing talks like today, but first it's advocacy with host governments. It's a responsibility. It's also self-interest. It's no good to vaccinate part of your population or your own people and think you're going to solve the problem with the body of displaced persons in your country who are not vaccinated. So no one is safe until everyone is safe. Second, we need to make sure they're included in all the national plans. But what do we do? So maybe just two concrete examples, Syria and Yemen. You asked me about that. In Syria, the COVAX facility has been approved and the government has confirmed that refugees and camp-based displaced populations will be included among the priority categories when the vaccine campaign is rolled out. We have been able, as UNHCR, to continue our registration of refugees and populations of concern, meaning displaced. And we are working to get them to have access to 14 primary health clinics, as well as 30 health points across 10 governorates. And that's, I think, already a step forward. Yemen is slightly more complex in some ways. Well, actually, they're both complex. In Yemen, the virus continues to spread mostly undetected in some of the most impoverished communities. And in particular, refugees, asylum seekers are really at a heightened risk due to their dire living conditions and sanitary conditions, their hindered access to health facilities, and a real increased stigma which is associated with the virus. But UNHCR is working very closely with the authorities to ensure that displaced refugees are also included in the national and preparedness plans and can access adequate healthcare services. I understand that Yemen's national COVID-19 vaccination plan has been recently finalized, and that there is going to be 2 million doses in the coming months through the COVAX. So I would say, Jordan is a great example. We heard it. But what is UNHCR doing? We're working at all levels to guarantee inclusion. And we're also part of the COVAX Alliance that just yesterday approved that 5% humanitarian buffer, which is so important, 100 million doses for humanitarian purposes. So that's a step in the right direction. That's good news. And we also heard from Dr. Hajjeh the role that we're working with, which is with the international financial institutions, with the World Bank, with the like, to support countries like Lebanon as well. So complex issues and ones to which we don't have all the answers. We've had 8 of our staff die of COVID, trying to reach the most vulnerable populations in Sudan, in other countries, and trying to do our work. So there's also a real vulnerability for the first frontline workers as well. Thank you, Rosemary.
Thank you so much, Dominique, for joining us. That was very helpful. And in fact, not surprisingly, knowing you responded to a number of the questions that have been being raised. I'm going to now go to some of those questions. I've been kind of collecting them in the background in the Q&A, and some of the ones that were given to us in advance. I'm going to start with one that there's 2 questions, in fact, that I'm going to combine. One is the question of, are the levels of vaccine hesitancy higher in the refugee population than the general population? And the other part of that question from another one of our guests was with respect to the info pandemic and the rumors about the vaccine, and how is that impacting the lack of vaccine confidence or vaccine hesitancy in refugee populations. Rana, why don't I start with you?
Just to unmute myself. Yes, thank you, Rosemary. I mean, this is, previously we were actually lucky to be one of the regions with the relatively least vaccine hesitancy, but this has been an infodemic, as was mentioned. A lot of issues, a lot of reasons for that. Partly it's the lack of trust, sometimes, unfortunately, which is an issue. I don't have a clear answer to your question. We are trying, there's a lot of rumors circulating, but we are trying to do some studies to assess the the beliefs of the populations, both at the overall country level, as well as some of the vulnerable populations as well. So I don't know if it's more. I don't have, at least based on some of the limited data we have, I don't think it's more among the refugee communities compared to others. And actually for many of the refugee camps, we have already started by vaccinating the healthcare workers and some of the other high-risk groups, similarly to the countries. And we don't see a lot of vaccine hesitancy among these groups. So I hope it's not, but we won't really know until we finish collecting some of the data. We're in the process of doing that. What we also do is we monitor a lot of the social media right now to see what's happening in terms, what's trending in terms of the rumors, etc. So kind of trying to keep our finger on the pulse of these rumors and try to manage them as quickly as possible.
Dr. Jaber, would you like to comment on that question in terms of your experience with vaccine hesitancy being higher or the same among?
Generally, in the refugee camps, vaccine hesitancy is far less than in the general population because they don't have easy access to social media and rumors and so on. And they have more trust in the NGOs and people helping them. On the other, we see less vaccine hesitancy as the number of deaths increasing and the number of cases increasing in our region. So the early hesitancy has changed, and the number of people registered on the platform for vaccination have increased markedly in the last couple of weeks. So we believe that 20% of Jordanians at least will be registered to receive their vaccines within the coming 3 weeks. And this is very important because the rumors was very strong at the beginning, but now they have vanished, and more people are registering to receive the vaccine. Especially, it has been organized 270 vaccination centers are distributed in the country. So there is ease and organization. The level of organization is high. So the experience of people in receiving the vaccine has been pleasant generally. So the people are changing now their opinions, and in the social media, the attacks on vaccine has lessened by 80% in the last couple of weeks.
Okay. Thank you for that. It's really helpful. And I think it's probably very good news, because certainly among other vulnerable populations, some of the early data seems to suggest, for example, in the United States, that racialized populations may have more lack of confidence in the not just the vaccines, but in the kind of the health systems in general. So there's early data being collected that would suggest, and so it's good to understand from point of view of the refugee population that you've been able to manage that in a way that there isn't an uptick in vaccine hesitancy. I have one other question that has to do with the role of civil society, and it came in 2 or 3 different types of questions. But the role of civil society in Jordan and the region in terms of operationalizing the rollout of the vaccines, because they tended to be trusted entities as well. And particularly, there was a specific question around the Jordan Health Aid Society International and the use of NGOs to roll out the vaccines in Jordan. So maybe you could both speak to that in terms of civil society's role in this.
Well, civil societies are closer to the population than, the governmental level. So we strive to them at the early stages of vaccination to help us to gather people and organize things. So it was kind of gathering at the time of embargo, or at the time where no one can move, but with the social distancing and so on. So they were good partners in changing the mentality about vaccination, and also in reaching remote areas or some particular societies, because there are many levels of representing the people in Jordan. It's not only the parliamentary members, but also we have local societies and groups that represent the region and reflect their interests. So we strive to them, and they helped us a lot. And they are literally now active members of the vaccination team by organizing the health vaccination centers, by each one bringing his relatives, friends, and trying to spread the word that vaccination is safe and it has no complications, and giving life experiences from people not receiving the vaccine versus people who received it in the term of being affected. So yes, civil societies are very effective in Jordan, and it helped us, especially even in the camps. We have civil societies from the refugees themselves. talking about their interests, needs, and they talk in two parallel pathways, one to the governmental representatives and one to the international NGOs, mainly UNHCR and the WHO representative in Jordan. I would like to stress here that the WHO representative of Jordan is part of our National Committee for Infection Control. Mm-hmm. By law in Jordan, she is part of it, and she participated, Mrs. Maria Cristina, in all our meetings in putting the policies, which showed that our tight relation with the international community.
Right.
Thank you.
Thank you very much. I am going to, there's an excellent question in the Q&A around the issue of WTO and the TRIPS provisions around mandatory licensing, etc., in situations like this. And I'm going to ask Zain Dangor to come on the screen. Mr. Dangor is the South African political advisor to the Minister of International Relations and Cooperation. And he had suggested that he'd like to, he was going to raise the question, but he would like to also respond to the question that's been posed in the Q&A. Mr. Dangor, if you go off mute, welcome.
Hi, good afternoon and good morning, and thank you for allowing me to say these brief words. It's a really great discussion, and I think it's going to help us also in South Africa and the region to deal with refugees and other vulnerable groups in our national plans. I think I've learned a lot in terms of what we can put into our national plans in this brief discussion. What I wanted to reflect upon, and I think the mindset issue was raised quite earlier on, and essentially what we're finding is that this global pandemic has changed the world, has impacted everybody across the world. But we still see that the manner in which treatment rolls out doesn't recognize that fact. You still have a sense that some people are more important than others. And that is, you know, sort of a variant, to use a bad word, of vaccine nationalism that has emerged. What we're proposing, initially together with India and now with the support of the EU and 100 other countries, is that we need to change the shift of vaccine distribution from one that's centered around philanthropy to one that is focused on systemic change, to shift the asymmetrical kind of structures where vaccines are produced in the north, consumed in the south, and often at quite high, at high costs. And therefore, what we're proposing is that to meet some of the global demand, the TRIPS waiver on some of the patents may incentivize production in the south. And we're seeing through research done by Medicine Sans Frontiers, done by our own Department of Science and Technology in South Africa, that with the right incentives, with the blueprints, and with the guarantee that there won't be countermeasures, you know, manufacturers in the south will repurpose their facilities to produce in a reasonably good time. And we feel that that's probably the best way to not only save lives now through breaking the chain of transmission, but importantly also lay the basis for us to be better prepared as the global community for the next pandemic. And it's important for us that the Committee on Economic, Social and Cultural Rights has also called on member states to support, whether through a vote or through consensus, the TRIPS waiver, because it does away with this idea that nobody's safe until everybody's safe. It's not just a slogan, it's actually in this pandemic with this virus, it's a reality. So again, thank you for that. I've put some of that on the chat as well. And we've got a document and lots of it that we can share if necessary. Thank you.
Absolutely. Thank you very much for that intervention. And certainly, I think when you have the key institutions of WTO and WHO and WIPO, all three that are this is in their bailiwicks, their wheelhouses, and they sit side by side in Geneva. I'm sure that there's going to be a way to work through kind of the best way to make all of this happen, so we do indeed achieve access for all who choose to do so. I am looking at the clock, unfortunately. I try not to look at it too much, but that is my role here. And I would like to ask or invite the panelists if they would to come back on screen and kind of if you have any remarks you want to say, kind of 1 minute, kind of a 1 minute round of something you didn't get to say. So Rana and Dominique and Anders and Dr. Jafar, if you come back on, and we'll do a quick round. Rana, do you want to start? I can see you first up.
Yeah, no, thank you very much. I mean, this is really a great opportunity. And, you know, I've been thinking while we're on the screen about like, how can this help the refugees more? I mean, of course, by sharing information, sharing experiences, lessons learned, but I think also advocacy, as was mentioned already. I mean, I think to be the voice, as we say, of people who have no voice. And I think, you know, maybe to end on a positive note, I mean, we're in the region, you know, we have, because I mentioned financing as a big issue earlier, and I know there's a global shortage, but we have the month of Ramadan coming up soon, in 2 weeks, actually, and this is the month of good deeds and donations anyway. So I think, I mean, we would encourage all, of course, donors and stakeholders, specifically in our region and globally, to think about more donations, at least for this coming year, until the whole situation gets a bit more well established and we're actually working with our resource mobilization team to mobilize more resources for vaccines for all our vulnerable countries and hopefully for refugees and migrants. And just wanted to make a comment because I think Dominique mentioned the Yemen. Yemen is supposed, so far we have 20 of our 22 countries have already started vaccinating for all of their populations. And Yemen will be receiving vaccines on March 31st, en principe. So I hope that this will be achievable. And by that, it will be the last country in our region to actually start vaccinating, hopefully within the next couple of weeks. So very excited about that.
Absolutely. Thank you so much, Rana. Anders. You can unmute. Perfect.
No, thank you. No, just one reflection that has to do a little bit about the vaccine hesitance, but also something I learned and experienced when I was the head of the WHO country office in Sierra Leone during the Ebola outbreak. That was the community engagement and the empowerment of people, and how you are actually able to see and reach out to people by recognizing the power of people. There was a lot of top-down communication at the time when at least when I arrived, talking to people instead of talking with people. But we invested a lot in the community engagement, reaching out, speaking to people, sitting out in the villages, sitting out in the worst slum areas, being there, being available, talking to people, and by doing that, also understanding people in a different way. And by doing that, also in some way releasing the power of people. So for me, that was an extremely important experience. And I think, again, all of this comes down to people. And it's not just taking care of people, it's about also empowering people and equipping people with the necessary, of course, tools, but also positions and knowledge. Thank you.
It's a great summation and a good lesson that we learned from Ebola, and hopefully we're carrying it forward through COVID. Rana, can I turn to you now? Oh, sorry, I already did. Saad, Dr. Jafar.
Thank you very much. It was an honor.
We're on this side of my screen.
I would like to stress, I mean, my military background affects me always. I think as this is a global problem, I think it's the role of United Nations to put an action plan to reach the forcibly displaced and to reach the least fortunate nations in an active way, and it works and should work to have a political will from major powers and major economic groups, because no one's safe unless everyone's safe. So there should be an action plan which should called upon to be implemented to reach everyone, vulnerable groups, so that worldwide. Otherwise, because we know the problems with logistics, financing, and so on, and this won't be solved unless there is an action plan which we can all together advertise and work together to be implemented. It is not only in the Levant area, but there are many countries, many areas in the world, even in Europe, where they don't have a good share of vaccine. So I think we have to work together, and the best one to work to do this role is the United Nations, mainly WHO. And I think, I hope we will see this action plan soon to emerge.
Thank you very much. And to that point, a successfully managed vaccine distribution system is going to be the cornerstone of strengthening multilateralism and the United Nations for the future. So thank you for that. This 1 minute round is getting all kinds of good insights. Dominique, you get your 1 minute before we turn to Prince Hassan.
3 points. So first of all, many countries simply don't have the resources to roll out the vaccines, whether it's the cold chains, whether it's staff, whether it's awareness. So there needs to be bilateral aid to those countries directly to support them for that rollout. If not only refugees are going to get it, but also their population. So I think the issue is global in that sense. The overall economic crisis that is facing refugees right now is almost as dire as the vaccines. You're seeing poverty increase in Lebanon. You've gone to over 85% of the refugee population in Lebanon is at extreme poverty levels, which is up from 55% a few years back. So that situation is almost becoming more overwhelming. What do we do about that? And last, actually, refugees, we heard this from Lloyd, refugees do have a voice, displaced populations have a voice. We've heard it across Canada and how they've been actually a part and parcel of the COVID response as well as health workers. And I think that's something we need to listen to them, we need to ask them as well. And I think that's what we heard today. And thank you for organizing.
It's a pleasure. Thank you very much. I think one of the things that has come out, at least for me, is that the importance and on what you just said, Dominique, and what Dr. Jabbar, everyone has said, is that the distribution has to be also according to a set of transparent, equitable, scientifically sound principles. That's where we'll build the confidence and trust in the global system again. And as you say, where you live shouldn't determine whether you live. And someone said this very poignantly in the Q&A. So global solidarity is protecting lives and protecting livelihoods as well. Let me turn to His Royal Highness Prince Hassan for a final word. Prince Hassan.
I think it may be time to separate disasters into 4 categories, 3 of which have run into each other and complemented each other. One is elemental, the other is foreseeable, and the 3 is deliberate. And I think that these 3 terms apply to what we are living today. The 4th, of course, is accidental. And Jared Diamond puts it very eloquently. He says, climate change, resource depletion, and inequality pose far more serious threats to our survival and the quality of life than the current pandemic does. Speaking to Arab water ministers last week in Baghdad, and speaking in September, possibly to another Arab water minister meeting in Abu Dhabi, the climatologists have pleaded with me more than once that please help to sensitize them to climate issues. The health people have done the same. Please help to sensitize them to water and sanitation issues. So I think that the question that we have to face, it's all very well to say the Levant in passing is an issue, but let me explain. It is an issue of bilateralism versus multilateralism. If each of these proxy countries in the Levant continues to look to its benefactor from outside, as in the initiative of the Serum Center in India, which of course is very well recognized, and I thank both South Africa and India for their initiative. That is all well and done. But in terms of the more recent Sputnik and global initiatives taken by Russia, I think it's very important through Gulf countries, for that matter, to sum up, if I may say, by saying that the issue is not that the vaccines are scarce, as for example, oil is in Jordan, but that the vaccines have been made scarce by supply-constrained conditions, as in the words of the WHO, when they finalized their concept for fair access and equitable allocation of COVID-19 health products. So I would conclude by quoting and saying a civilization that prohibits poorer nations from producing life-saving vaccines in the midst of a global pandemic is a civilization that is morally bankrupt.
Thank you very much, Hassan. A lovely way to end. And as one of the refugee voices that was in our audience today said, it shouldn't matter where you live, that determines whether you live. And so thank you all. Thank you to the panelists and to those who joined in very much, and to the audience, many great questions. I do think we did a pretty good job covering most of them. Many of you picked and anticipated. Thank you to CUSO for making the event possible. The WRMC and CUSO have a very unique civil society relationship. And to the question in the panel, yes, this will be, it has been recorded and it will be available on the WRMC website within a day. So someone said they'd come in a little late and wanted to hear it all. So yes, it will be available. So many thanks to all of you. Please stay well, and I'm sure we will have opportunity to meet again. Thank you.
Thank you all.
Thank you. Bye-bye.